This meeting is being recorded.
And for, I think, the third time, we have Dr. Lewis with us. Dr. Lewis with us, and we sure do appreciate your dedication to ILR. So thank you for being with us, and I'll let you go ahead and begin your program.
All right, thank you so much. Just like everyone said, this is the third time that I've come and presented for you guys. I hope that you guys have enjoyed this set of presentations and actually learned something and gained something that you plan to put to use. Today, we are going to be talking about addictive disorders, substance abuse disorders in the elderly. And I just want to thank you once again for allowing us to do these presentations. And I hope that you guys have enjoyed the presentations. So now I will begin to share my slides, which I should have done earlier. But yes, thank you once again.
Dr. Lewis, you've muted yourself.
So something happened when I shared the slides that it turned off the audio, but it was checked. So when I clicked, it says share audio tab. When I click the slides.
Okay, go ahead and try again.
Okay.
But so we can see your slides, but now go to your microphone. It's still muted.
Still muted. Yes, I'm unsure. Hold on, because this hasn't done that in the past. Where when I start sharing my slides, it. Let's see if I do it this way. If that'll help. So you guys can hear me now. Oh,
we can.
Let's do it here.
There we go.
So
we can see you and hear you. Okay. Thank you so much.
Okay. Well, I am not sure why that was happening, but thank you for letting me know. Okay, so like I said, I am Dr. Ashley Lewis. Today we'll be talking about substance abuse in the elderly. The objectives for today, we'll be talking about the DSM-5 criteria for substance abuse, discuss risk factors, discuss epidemiology, as well as discussing treatment/screening. So in the DSM-5, you have many different types of substance use disorders, substance intoxication, substance withdrawal, or other substance-induced disorders, as well as unspecified substance use disorders. So in the DSM-5, in order for it to become a use disorder, you have to meet the criteria for the many different things that we're going to be talking about here. So on this slide and the next. So taking the substance in larger amounts or for longer than you meant to, wanting to cut down or stop using the substance, but not managing to, spending a lot of time getting, using, or recovering from the use of the substance, cravings or urges to use the substance, not managing to do what you should at work, home, or at school because of the substance use, continuing to use even when it causes problems in relationships, giving up important social, occupational, or recreational activities because of substance use, using substances again and again, even when it puts you in danger, continuing to use even when you have physical or psychological problems that could have been caused or made worse by the substance, or needing more of the substance to get the same effect that you want, which is tolerance, or development of withdrawal symptoms, which can be relieved by taking more of the substances. So from this slide and before, if you've had 2 to 3 of those symptoms, then you have a mild use disorder. If you have 4 to 5 of these things that we've discussed, then you have a moderate use disorder. And anything 6 or greater is a severe substance use disorder, according to the DSM-5 criteria. Things that can increase your risk for substance use would be psychiatric conditions like depression or anxiety. When people say they are self-medicating with different substances, trying to assist with their anxiety or depression. Multiple medical conditions, including chronic pain, when someone is having caregiver strain, psychosocial stressors like loss, social isolation, loneliness, boredom / retirement. So the different types of substances that are included in the DSM-5 will be alcohol, stimulant use such as cocaine or different stimulants. Adderall is considered a stimulant as well. Tobacco, cannabis, opioids, sedative anxiolytics, which is our benzos, hallucinogens, inhalants, and caffeine. Is there room for concern? Because just, having a drink socially here and there does not mean that you have a use disorder. So is there something to be concerned about with the amount that you're intaking of the different substances? If you're having long-lasting like side effects like confusion, memory problems, slowness in regular movements, if you're noticing that you have mood lability, anxiety, depression, psychosis, or insomnia, if you're having more falls, injuries, noticing some malnutrition, poor hygiene, noticing tremors or change in balance and gait, as well as noticing increased isolation or more frequent requests for refills before time or family discord. So when talking about alcohol, we have the National Institute of Alcohol Abuse and Alcoholism, and they have created some guidelines for those who are 65 years and older. So if you're a healthy older adult, the recommendation is for less than 7 drinks per week. And if you're older than 65 years, the recommendation is less than 3 drinks per day. So older adults with medical conditions or those taking medications that would interact with alcohol should consume less alcohol or abstain completely. And so during the previous presentations, we talked about anxiety or depression or different things like that. And if you are on some kind of psychotropic medication, we do say that if consuming alcohol or using any substances, you will not get the full benefits of the medications. So it is kind of recommended for you to abstain from substance use so you can get the full benefits from the medication for your depression or anxiety. In recent studies for alcohol in 2019, for the National Survey on Drug Use and Health, for binge drinking in the last month, they showed 10.7% in the population. For heavy alcohol use, they showed 2.8%. And at-risk drinking, they showed 65%. And numbers may be higher due to underreporting, as well as social or occupational impairments may be missed as many older adults live alone, are retired, or are socially isolated, as well as poor screening due to fear of offending or false assumptions. And another thing to consider is, I don't have the data for the results after COVID, but we do have some reports that the incidence and the prevalence of drinking and substance abuse increase after COVID. Alcohol use disorder in elderlies, in elders can increase the risk of hospitalizations in older adults, more hospitalizations than related to MI. You can also have comorbid medical conditions, mask signs of harmful use. So what that's saying is like your substance, your comorbid conditions can mask the harmful use of the substance abuse. because there might be some overlap of symptoms that the person is having. Screening for alcohol use disorder. So there are several different screens that can be used. The Substance Abuse and Mental Health Service Administration Treatment Improvement Protocol consensus panel recommends screening once a year. So I listed several different screening tools that can be used. So we have the alcohol use disorder identification test, and the cutoff is at 5. We have the CAGE questionnaire, but they're saying that it's not as useful in this population, but it is an easy screening tool that a provider can use to see if other screening tools should be applied. We also have alcohol use disorders identification test consumption. So the score is from 0 to 12, and a 0 will indicate no alcohol use. A score of 3 or more is a positive screen. You also have the Senior Alcohol Misuse Indicator and the Short Michigan Alcoholism Screening Test, geriatric version. So all of the screening tests on this slide, the intention is just to screen for frequency and amount. So it's how much are you drinking? Have you tried to cut down on your drinking or substance use and been unable to? So it's just trying to see if other screening tools should be used at this point. So if screening is positive, at that point, you want to once again do a comprehensive assessment. So once again, talking about frequency, severity, the history of use, kinds of problems and frequency, physical and mental health consequences that the person has experienced, as well as family, vocational, financial, or legal history. So then you want to also do a physical exam as well as blood work to see if there's any electrolyte imbalance which you want to replace, as well as on admission you want to do like a blood alcohol level. So evidence-based interventions for alcohol use disorder. So you have some screening, brief intervention, and referral to treatment, which is easy to incorporate into regular clinical care. You also have brief alcohol interventions, so which is time-limited conversations focused more on harm reduction than abstinence promotion, as well as motivational interviewing techniques are frequently used in the brief alcohol interventions, and both of them together can be a part of the screening, brief intervention, and referral to treatment. So for psychoeducation, you want to raise awareness of medical consequences like increased fall risk, worsening of cognitive deficits, or liver damage. So when you're talking about alcohol withdrawal symptoms, some of the things that you can see, you have increased blood pressure, increased temperature, restlessness, sleep disturbance. You can have some anxiety, nausea, some tremor, as well as withdrawal hallucinations. It can be auditory, visual, or tactile, as well as alcohol withdrawal seizures. So when you're talking about substance withdrawals, there's only 2 substances that you need to be hospitalized for to withdraw from, and alcohol is one of them. The other substances, well, I'll get to the second one, but alcohol is one of the ones that it could be a medical emergency. So you don't want to just stop cold turkey if you have been consuming high volumes of alcohol. Because you can have a complicated withdrawal period. So you want to go to the ER or your primary care physician to get some assistance on next steps. Treatment. So once again, level of care, could it be outpatient, office-based versus change in setting? So needing to go to the ER versus medical floor versus the psychiatric floor. Outpatient substance use disorder treatments versus long-term rehab. depends on the severity. So the risk of withdrawals, including seizures or DTs, the blood alcohol level, physical or functional decline, or cognitive impairment. So most people don't prefer outpatient detox in older adults due to the comorbidities requiring medical supervision. Once done with detox, you may transfer to a long-term rehab or ongoing assistance with recovery management support. Some other treatments, so older adults are at a greater risk of complications like confusion, no detox guidelines specific to older adults. And this once again talks about the electrolyte replacements and wanting to replace thiamine, use of SIWA to help guide detox. So that's something that we use to monitor withdrawal symptoms for alcohol. And benzodiazepines are the mainstay for treatment. So when somebody is coming off of or withdrawing very severely from alcohol, we treat it with benzos. So once again, treatment options in older adults, you have potential drug-to-drug interaction, recovery supports using lower doses. Another medication that can be used is naltrexone for alcohol use disorder, as well as acamprosate, the disulfiram is the antabuse, and then there's some off-label medications, gabapentin or topamax, that can be used as well for alcohol use disorder. Comorbidities/complications. So once again, substance use disorders, they can present with other psychiatric conditions. So for alcohol use disorders, they can also present with affective disorders and depression. One thing to note, they noticed that alcohol abuse earlier in life has shown an influence on late life depression. So it was shown that a person that did have exposure to earlier in life alcohol abuse, the late in life depression was more severe and had a more chronic course of depression. And some complications you can have, like an alcohol related dementia, as well as alcohol impacting sleep. So it decreases stage 4 sleep and can aggravate sleep apnea. So the sedative, hypnotics, and anxiolytics is just how we talk about benzos and the DSM-5. So once again, the most recent American Geriatric Society guidelines discourages prescribing benzos as a first-line treatment for conditions like insomnia or anxiety. And the reason for that is due to the increased risk of cognitive impairment, falls, hip fractures, the potential for addiction, and motor vehicle accidents. So some of the interventions that were researched was something called the Empower trial, which showed a reduction of 27%, as well as the deprescribing trial, which showed a discontinuation rate increased to about 43%. There was another multidisciplinary approach to the deprescribing in the geriatric primary care, which showed about a 39.8% discontinuation rate. So I think in the past, when the benzos first came on board, the long-term side effects that we are now seeing wasn't so apparent. But now, due to the facts that we're more aware of the cognitive impairment, as well as the risk for falls and hip fractures, as well as the potential for addiction, benzos is no longer first line for treatment of these disorders like insomnia or anxiety. So now, moving on to opioids. In older adults, they have a higher risk for misuse due to initially the medications possibly could be prescribed from a physician, but you know, it is very possible once someone becomes more elderly, you can misuse it on accident in ways such as taking a different dose, taking an incorrect dose, maybe forgetting that you took your medication and now you're taking another dose, as well as sharing medications, obtaining from non-medical sources, as well as use with alcohol or other substances. At times they can be unintentional and they don't realize they are doing it. So that's kind of like what I was saying, you know, it could be a mistake, but you still have that same risk and concern of increased use and misuse. So opioid use disorder. So this study was from 2013 to 2015. 55 plus population increased by 6%, and the treatment seeking folks increased by 54%. Also, in 2008 to 2017, there was a 25% increase in opioid related deaths in the 55 plus population. So when you're talking about opioid withdrawal and detox, for opioid use disorder, it's more uncomfortable, but it's not necessarily a medical emergency. You'll have symptoms like nausea, vomiting, diarrhea. Just think about being very leaky. So detox, do not do it. Do not do rapid detox in older adults. You have a higher risk for arrhythmias or electrolyte abnormalities, deconditioning from prolonged withdrawal. You can use clonidine to monitor the high blood pressure, or COWS to monitor withdrawal symptoms. Loperamide, and if using anticholinergics, use with caution. And NSAIDs, monitor for risk of bleeding. So there are several different types of treatment. If you want to do a medication-assisted treatment for opioid use, you can use buprenorphine or methadone. It causes a significant decrease in cravings. When you're talking about between the two, buprenorphine is less sedating, has stable metabolism, and a less risk for cardiac side effects. But it was shown that quality of life was better with methadone treatments. But if someone is on methadone and develops falls, confusion, QTC prolongation, or transition to a structured setting like an assisted living facility or a nursing home, plan to taper off the methadone and maybe transition to buprenorphine. So in terms of non-pharmacological treatment options, you want to connect to social support, such as church, family, friends, mutual self-help groups. You have the 12-step, like the AA groups, problem-solving therapy, relapse prevention therapy, as well as telephone counseling, contact with caregiver, as well as self-management and recovery training, which is an alternative to AA meetings based on CBT and motivational interviewing. More non-pharmacological treatment would be build the therapeutic alliance, focus on nutrition and exercise, involve family and friends, so increasing that social support, address loss and isolation, and once again, treat those psychiatric comorbidities. All right, so that is the end of this presentation. And I want to once again thank you guys for having me and open the floor for any questions of what you've heard today.
Thank you, Dr. Lewis.
Yes, thank you.
Do we have any questions among the audience here?
How about on Zoom? Does anyone have any questions or concerns?
Everybody's so medicated, they're at peace with the world.
A nice audience today.
Yes, Richard, Dick.
Yeah, could you go back to one of those earlier slides? You were making presentation about the frequency of problems. And I thought you had something there where you said that 65% of the population has a problem, which seems...
No, sorry, it was saying that 65% was showing at-risk exposure.
Okay,
So
what does that mean, at-risk exposure?
So maybe just showing some concerns for further screening, but not necessarily saying that they have like the substance use disorder.
So you are not saying that 65% of the population has problems.
No.
Okay.
No,
So approximately what percent of the population does have ongoing problems with alcohol?
So hold on, let me go back to that slide. So what it did show was that 10.7% showed binge drinking in the last month, and about 2.8 had heavy alcohol use.
Okay, so heavy alcohol use is something that's continuing. In other words, they're drinking excessive amounts.
So they would have the substance use disorder.
And that's about 2.8% of the population. Yeah.
Sorry, say that one more time.
In other words, you're saying that 2.8% of the population is drinking too much on a regular basis.
They are having, yes, increased alcohol use, heavy alcohol use, yes.
Okay, yeah, thank you.
In 2019.
In 2019.
Some of us are suspicious that it's greater number than that, but
Well, I did mention that the numbers went up after COVID, which isn't representative. So yes, it can be higher than that. Yes.
All right, I have a question here on Zoom. Hi, Shirley, go ahead.
Hi there. Very interesting topic. You may have mentioned it and I may have missed it, and it's risk of exposing myself. Are there any particular well-known medications that alcohol is contraindicated for? If you take so-and-so, don't drink any alcohol at all. Are there any?
Well, I would say that there are many, especially psychiatric medications. You won't get the full benefits of the medications. So that's one of the things we recommend that you abstain if you're on any psychotropic medications. There are some medications, like if you're on like a pain medication, like an opioid, because alcohol can depress the respiratory drive. So you don't want that to happen when you combine alcohol and like an opioid pain medication. So that's one of the concerns. So there are several medications that can interfere with, alcohol can interfere with several medications. Yes, so I would
use these medications to commit suicide or to have a planned death.
Can you repeat that question?
Do seniors ever use these medications to end their lives, to have a planned death rather than continuing in a life they're not happy with?
Do you mean alcohol or substances, period?
Any of these combination of things.
Yes, it is possible that they can overdose from a medication. Sorry, I don't know if you saw that. I don't think I'm screen sharing anymore. But yes, it is possible for this population to
deliberately do that. Is the older
Yes.
population involved in the fentanyl epidemic that's going on?
I would assume so, since the fentanyl/opioid epidemic is increasing, and it's one thing that we're struggling with right now. Yes.
Yeah. Thank you. Very interesting.
Thank you.
So can you remind us who did the study that indicated 7 drinks a week or 3 a day for the elderly? Because the Canadian Medical Association just put out a study that said no alcohol is, recommended or healthy, including for those of us who keep saying our red wine is good for our hearts.
Yes. So the study that I got, it was from the National Institute of Alcohol Abuse and Alcoholism that I got my specific guidelines from. I mean, it's definitely recommended that abstinence is preferred, but sometimes that isn't plausible for some people. So just giving them a like saying less than this is better than a higher amount. But yes, abstinence is preferred.
I mean, they used to, as I remember, there were suggestions in the past that moderate drinking in the range of 1 to 2 a day, depending on your size, might actually be good for you. And I think what's interesting about the Canadian issue is either the Canadians are more sensitive than Americans, or it's the usual kind of thing that different sets of data will give you different conclusions. Is there somebody behind me? No.
Nope. I don't see any other questions, but I know that we are so grateful for your whole department and all of the information you've been able to share with us these last 6 weeks during this course. Anything else?
Thank you, Ashley.
Thank you so much. Thank you for having me.
And
I love the participation that I always got.
And extend my appreciation to Jackie for helping to organize this set of lectures. Okay. We hope to see you again.
All right. Thank you so much. Bye. Have a
Take
good
care,
day.
everyone.
Bye-bye.
Bye.